Good day, ladies and gentlemen, and thank you all for joining us for this National Institute for Healthcare Management Foundation Early Childhood Education Partnering Up to Amplify Impact. To get us started with opening remarks and introductions, I am pleased to turn the floor to your host, Catherine Santoro. Welcome, Catherine.
Thank you, and good afternoon. I am Catherine Santoro, Director of Programming at the National Institute for Healthcare Management Foundation, and on behalf of NIHCM, welcome to our webinar today. For every dollar invested in high-quality early childhood education, society receives up to a $7 to $12 return on investment. The health and economic impacts have been documented by extensive research. Children receiving high-quality early childhood education are at lower risk for heart disease and obesity. They also stay in school longer and earn more income as adults, helping to close the income inequality gap. Yet, American parents continue to struggle to access and afford available programs, which means there's more work to be done to ensure all kids have a healthy start. Today, we'll hear from a prestigious panel of leaders who are working to advance access to high-quality early childhood education across the U.S. They are leveraging partnerships to amplify the impact we know these programs can have on current and future generations of children. Before we hear from our speakers, I'd like to thank NIHCM's President and CEO, Nancy Chalkley, and the NIHCM staff who helped to convene this event today, including Caitlin Smith, Kate Ellis, and Kirsten Wade. We hope you'll also take a moment to explore work NIHCM has supported through our journalism grant program on this topic. You can check the resources tab in the webinar console to learn more about our support for a documentary public engagement campaign to raise awareness of how early childhood learning is tied to short and long-term health outcomes. You can also find biographical information for our speakers along with today's agenda and copies of slides on our website. And we invite you to live tweet during the webinar today using the hashtag early childhood. I am now pleased to introduce our first speaker, Allison, Baulos, Executive Director of the Center for Economics of Human Development at the University of Chicago. In 2014, with Nobel laureate economist Professor James Heckman, she co-founded CEHD. She directs the Heckman Equation Project, which disseminates research on early childhood to policymakers, nonprofits, and the business community, and creates resources for advocates to more effectively make the case for economic investment in early childhood education. She's also the Executive Director of the Human Capital and Economic Opportunity Global Working Group. The seminal work of Professor Heckman, Allison, and their team has established the importance of investing in early education, and we're so honored to have Allison with us today. Allison?
I'll talk about innovative research out of my organization, which is the Center for the Economics of Human Development at the University of Chicago. This work was accomplished through collaborations with our partners and funding from private organizations and NIH. Frank Porter Graham at UNC ran the original study that I'll talk about, and the Schaefer Center at the University of Southern California partnered with us on a cost-benefit analysis to where we could factor in health. Abecedarian was a center-based early childhood education program, and the study associated with this assigned children at birth to a treatment group which attended the Abecedarian program or a control group who went to either, and they chose to either go to lower quality child care centers or stayed at home with family or caregivers. When studying these programs long term, we want to understand not only the effects directly of the program, but also how the programs affect developmental trajectories, particularly for disadvantaged groups. So you can think of these programs operating through the dynamics or technology of skill formation, where skills beget skills. For example, early health might make one more engaged in class, which then boosts IQ, or socio-emotional skills can lead to better health, which will lead to employment stability. In 2014, with our partners at Frank Porter Graham, we published the first paper that demonstrated later life health effects of an early childhood program. And then after uncovering these robust lifetime effects, the next step was to conduct the cost-benefit and rate of return analysis to see if the program was indeed cost-effective. To quantify the importance of these findings on long-term health, our partners at USC have a model which allows us to examine the data. So given life conditions, for example, given life conditions at age 35, what's the likely projection for things like stroke, heart disease, hypertension, and medical costs going forward? And when we look at that long-term outcome, we find a 13.7% return per annum to the program. And the Abecedarian program is more than just early enrichment. It functioned, of course, as a child care center. It started at 8 weeks of age and was closed only 2 weeks a year. The same, of course, as many kids today who have working single or two-parent households. In fact, 25% of moms now are back to work within 2 weeks of birth, which is a really staggering statistic. The program was of high quality, which specifically meant that they had developmentally appropriate learning and curriculum that focused both on cognitive and socio-emotional skills. These were professionals who received ongoing coaching and stayed with the child through transitions, including the maintaining relationships into primary school. So when looking at education outcomes, there was no IQ, quote, fade out, suggesting that starting at birth matters. And the control group had childcare, but it was of lower quality, or they stayed at home. So the Abecedarian participants had better life outcomes than these alternatives. And when we break that down by gender, we see similar employment and education outcomes, but did also find that lower quality childcare showed negative effects for boys, more so than just staying at home. And as I'll show you, health plays an important role in this story. So the Abecedarian program went beyond cognitive and socio-emotional development and included health components, specifically nutrition, access to a doctor, and they had a nurse on staff. They screened regularly for physical health and developmental delays, and they identified health problems and referred them to outside medical care. And then they engaged the parent to connect and make sure that there was coordinated continuity of care. And when we interviewed the original teachers, we heard anecdotes of the importance of their daily contact with parents, where they were able to identify issues early and provide regular feedback. So let me see. Oh, I think these are the other slides. So UNC followed up at age 35, and our joint analysis revealed clear benefits to these investments in adult health. Significant effects included pre-hypertension, obesity, and cholesterol. In fact, for metabolic syndrome, which is a predictor of later life diabetes and heart disease, 1 in 4 men in the control group had these risk factors, but 0 in the treatment group did. So when broken down by gender, we see delayed drinking, healthier behaviors like exercise and diet for women, and for men we see higher levels of good cholesterol and lower obesity. Together, the effects of the Abecedarian program, which focused on health, nutrition, and learning, built a foundation whereby the skills on cognitive, socio-emotional, and health empowered opportunity for disadvantaged groups to close the gaps seen today, for example, today in income inequality and health disparities. So when these outcomes are monetized over the full lifetime, again, the joint work with USC showed a 13.7% return. These rates are driven by maternal employment and reduction in crime, and even improvements in quality of life. And when broken down by gender, you see particularly significant effects on income and crime for men. So what this means is we need to include health components in early childhood investments. And when these programs are cut, there are real costs associated down the line and strain the healthcare system with a higher burden of chronic diseases. As childcare is discussed in today's policy discussions, it's critical to attach quality. Boys are less resilient to low-quality care, which can even be harmful. And in applying a skills beget skills framework, you can understand this is a two-generation program. Mothers, because of the stability of the childcare, mothers gained education, labor experience, and those effects persisted even when we looked at them at age 45. Children were more productive in their own education and employment, and from a societal point of view, the program paid for itself just in the income gains to the mothers. So health and learning promoted upward mobility in a way that pays off for individuals, families, and society. And these outcomes are seen through to adulthood. When advocating for investments for early childhood development, early childhood education advocates can point to this evidence, and providers such as pediatricians, OB, infant mental health practitioners, and the like can see the long-term impact of their work. So you have to look at the full picture. This isn't just piecemeal. When talking about child care, pre-K, family leave policies, pediatrics, early intervention, you need to look at the comprehensive picture to understand the outcomes and the missed opportunities. Some of the work out of our center, we're following up this sample at age 45, including measures of microbiome and a protocol that connects to the Health and Retirement Survey. And we have a recent paper looking at a different program, the peri-preschool program, at age 55, where we see the children of the preschoolers who are now in their 30s, they have positive life outcomes such as education. So where this is a 2-gen program, you can also look at it as a 3-gen. So with that, I'll pass it back.
Thank you, Allison, for your leadership and commitment to disseminating this great evidence supporting investment in early childhood. I know you have a lot of great resources on the Heckman Equation site that will definitely benefit our audience. This research has really helped inform numerous efforts to support early childhood education, and we'll now hear about one of them, the Bipartisan Policy Center's Early Childhood Initiative. To learn more about this important bipartisan effort to improve the quality of early learning programs and sustain investment in proven programs, we're now joined by Linda Smith, Director of BPC's Early Childhood Initiative. Linda most recently served as the Deputy Assistant Secretary for Early Childhood Development in the Administration for Children and Families at the Department of Health and Human Services, where she provided overall policy coordination for the Head Start and Early Head Start programs and the Child Care and Development Fund. She's had an extensive career in early childhood education policy, from working to establish child care programs at the local level and within Native American communities, to strengthening early childhood programs offered by the Department of Defense. She's a national advocate in the field, and we're so grateful she's here with us today to share the important work her team is doing at BPC. Linda?
Thank you so much, and thank you to NIHCM for inviting me to be a part of this. I really appreciate the opportunity to talk about early childhood to the health community. What I wanted to do was to this is just an overview of what I'm going to talk about, who we are here at the Bipartisan Policy Center, an overview of early care and education in the country, some basic assumptions, and looking at the intersect between federal role in ECE and the state funding of it, and what recommendations we are making to the government, both at the state and the federal level. For those of you who don't know about the Bipartisan Policy Center, we are a nonprofit organization here in Washington, D.C. that tries to combine the best ideas from both sides of the aisle to promote the health and the opportunity for all Americans. In addition to early childhood, on the slide you'll see some of the other issues we work on: health, energy, housing, immigration, and a few others. We do our work through basically putting together bipartisan groups that will work on issues such as early childhood. One of the more interesting ones, I think, for this audience is when we started this work here at BPC in 2017, we had a task force co-chaired by former Senator Rick Santorum from Pennsylvania and former California Representative George Miller, a somewhat unlikely duo, to say the least. So what we're trying to do here at BPC right now is to look at, if you look at the second bullet on this slide, is to look at how we create a comprehensive and sustained approach to improving the quality of early care and education. And the two key words in this slide are a sustained and comprehensive approach to this. Much of the efforts in the United States have been rather random in approaching early care and education and looking at one slice of it, and we know that in order to make progress in ECE, we're going to have to take on this in a comprehensive fashion. So next we're going to do an overview of what early care and education looks like in the country, and I think some of these statistics I'm not going to read to you, but I think they speak for themselves. And I will say that I put information on these slides because I know the slides are going to be posted later on, and I thought the information might be helpful to the audience, even though I'm not going to read all of this to you, but just set the stage knowing that. Roughly 60% of our children between birth and 5 are in at least one weekly non-parental care setting in this country. That is a lot of children in these settings. These settings are very expensive for our families. If you look at the next one, 20% is the average they pay of their weekly household income. That ranges from anywhere 26% for low-income families down to 10% for higher income. We have a very complicated workforce with about 2 million paid teachers and caregivers in a variety of settings, and I'm going to show you what they are in just a second. But despite the high cost of care, the median pay for a child care worker in this country is less than $12 an hour, and that shows you roughly $22,000 a year, which is essentially poverty-level wages in this country. Many of them qualify for various public programs themselves, including food stamps, etc. And about 20% of the workforce in early care and education, according to the last survey data that we have, lack any kind of health insurance at all. And then the last point just tells you what the impact of the early care and education field is on the economics of this country. So in terms of, just wanted to focus a little bit more in on infants and toddlers because that is where we have such a critical shortage of care in this country. And as the previous speaker said, about 25% of our new mothers are going back to work within 2 weeks of giving birth, which is in and of itself a problem in this country, and one that there's some work going on already on paid leave and especially maternity and paternity leave. But because these years are so critically important, and as was brought out in the previous briefing, the quality matters, and it matters most to children from low-income families, and it really matters for infants and toddlers. So I think we've got to be thinking about how we approach this problem, especially in the infant-toddler spectrum, over the coming years. It's a crisis for our families right now. It's a crisis in part because the cost of it, in order to do early care and education well, we need to have good ratios between the adults and the children they care for, because adult-child interactions are key to just about everything. With that being said, that drives up the cost. So, for example, in infant care, infant caregiver ratios are roughly 1 to 4 in most states. If you think about what then that takes to pay that provider, whoever that is. That doesn't give you a lot of income if looking down at the next level, you're seeing that an infant, the cost of care for an infant is 11. So take 11 times 4, and you're at roughly 40,000, and that doesn't, that has to cover the cost of food, equipment, supplies, facilities, and everything else. So that's why we're really in a rut in terms of how we begin to pay for this. And I'm going to talk a little bit more about that in just a minute here. I want to talk first about some basic assumptions, because sometimes I get into conversations with people about this issue, and there's a perception in some places in our country as to child care, whether or not it's early learning. And of course it's early learning. As the slide says, children are learning 24/7, and every environment that they're in is a critical environment in the first few years of life. So child care is early learning, and what I generally say to people about it in terms of the quality of it, it can be good or it can be bad. And so the determining factor is, whether or not it's good, not whether or not it's educational. So the next assumption is that parents are so important in the first few years of life to what happens with children, and I think that goes without saying, and I don't have to say it to this audience. But I do think that for the most part, parents, we seem to think that we can take a child, put them in an early learning setting, and it will all work magic, and it won't work without the engagement of parents. And so we put a lot of focus on those in our work here, and think we need to have a more active conversation with parents across the country about the issue of early care and learning. In the next slide, I put this out here because we have been working on the issue of child care facilities in this country. And these are just a couple of pictures taken from an HHS Office of Inspector General report issued a few years ago, where they went out and did unannounced inspections of child care facilities in 10 states. This is the kind of thing we have going on in some of our child care facilities, and we've got plenty more where these pictures came from. We need to begin to address the environments that our children are in, and we've all dealt with some of the issues around lead and asbestos, etc., but we do have a significant problem with infrastructure, and so the health and safety in these programs can lay the groundwork for a lot of things that are yet to come in children's lives. And finally, this is an important thing for the healthcare world because developmental screenings are just really so important to identifying potential delays. And when delays are identified early enough, there are a lot of things that we can do within early childhood to help children move along the developmental spectrum. But if these things go without being screened, they just compound the problems that children have later on. So what I want to do now is talk to you a little bit about what early care and education looks like in this country. I think we tend to think of cute little preschool classrooms where children are busy and doing things, and that's the ideal that we want to all strive for. But within the early care and education system in the United States, we have a variety of options. And not all of them are in centers as people envision when they think about the preschool years. Millions of parents are using some of the options that I show here. We have centers run by national and regional companies, as well as small centers run by individual small businesses in communities. We have care going on such as family child care or home-based care. We have a lot of care in faith-based settings, part-day pre-K in schools and other settings, and then individual caregivers who go into the home, such as nannies and relatives. So it is a really varied system that we have, and it complicates, how to improve the quality because there is such variation in what we have out there. In recent years, we have seen a real increase in the number of children in center-based care, as the chart shows here. Close to 60% in center-based care now, moving away from other forms of care, but still a lot of children, especially younger children, in the in-home settings. Just to take a look at some of the other things, some families have access to publicly funded programs such as Head Start and Early Head Start or public pre-K. But the problem in that special piece of our market is that these are, generally speaking, part-day, part-year programs, and most families work full day year-round. And so we have a situation where we have many parents who are working full-time, relying on multiple arrangements for children to meet their needs. This is particularly challenging for low-income families, and it also is one of the reasons I've had this question frequently about the part-day preschool effort and why more children aren't in those settings. Well, poor families cannot take off work at noon to go transport their children from one program to another, so they tend to not use some of the things that would benefit some of our children the most. So we also have a problem, as the slide shows. There was a recent study released in Pennsylvania that looked at the non-traditional hours of care, and in that one study, there's roughly one slot for every 3 families that need that type of care. A lot of our lower income families work non-traditional hours, and this is a particularly challenging aspect of early care and education for them. So I want to talk a little bit about the federal role in early care and education, because I think in many cases the public is not as aware of where the funding is coming from for what is happening around the country. As noted in this slide, the federal government is the largest funder of early care and education programs in the country. No question about it. 80% on average of all money being spent in early care and education comes from the federal level or is driven by federal requirements. So that is a particular problem out there, and that intersect between these two things gets to be challenging because many people at the state level do not understand the background of where the money is coming from. So we have been trying to take a look at this and to try and figure out how do we begin to, as I go back to the first slide of what we're trying to do here at BPC, is figure out how we are going to sustain a high-quality early care and education system in this country. It's got to start with figuring out how to do the funding of it. So if you begin to, we have basically started to look at this intersection between the major funding streams and what's going on in the states, as I said. So at the federal level, most early education money flows through the Department of Health and Human Services. In FY19, as you're going to see in another slide, roughly $19 billion came through those 2 programs of Head Start and the Child Care and Development Fund. They account for about 90% of overall funding. It's coming from the federal government. And then I think in addition to that, as you know, most of our states now, 45 states and the District of Columbia, are spending state and local funds on state pre-K programs for 3- and 4-year-olds. Those programs primarily are, as I said, are part-day, part-year, and but they do all try to do the same thing, and it gets back to children learning 24/7. If they're in a part-day preschool or in a full-day child care, they are all learning. So this just looks at the funding streams and the amount of money going into those, and I put this in here for reference for you. One of the things that we have been doing here at the Bipartisan Policy Center is to look at those federal programs and look at how the states are using the money. So if you look at the GAO in 2017 published a report where they looked at the primary funding sources coming from the federal government to try to identify where there were inefficiencies in the program. In Washington, at the federal level and in Congress, especially in Congress, there is a perception that there's plenty of money out there if we were all just more efficient with the money. We set out to answer the question, are there efficiencies in these program funding streams, and if so, where is that efficiency? Where can we gain that? Because this issue of stovepiping, overlap, duplication of funding sources has been a barrier at times to us having conversations here and at the state level about increasing the funding for early care and education. So with that in mind, we looked at this. Despite the fact, though, that we have, you know, that much money, as you saw in the previous slide, going into these programs, we cannot meet the needs of families around this country. And I think that is where we really are, as I say, stuck. Head Start reaches only 31% of eligible children, and early Head Start 7%. So that's a very small number of poor children in the early Head Start program. The Child Care Development Fund served only, in 2015, served only 15% of the eligible under federal rules and 25% of those under state rules. And I can explain that in a minute when we look at a chart about the funding. But suffice it to say that there is not, no matter what we do, enough money in the system to provide the quality of care that we need in this country. So this chart looks at this issue of funding on a state-by-state basis. And this came out of a GAO report that was done a couple of years ago, where we tried to work with GAO to get them to sort of identify how much of the need was being met. The federal requirements for child care funding state that children up to 85% of state median income are eligible. However, the states have the ability to adjust that eligibility within as long as they don't exceed it. So this chart shows you where the states set the eligibility as compared to the federal. And no state is close to meeting the federal eligibility, and that is why we have such a, you know, a crisis in child care, if you will. And it's often, you know, basically a perception at a state level where a state will say we're meeting all of our eligibles. Well, if you set the eligibility low, then yes, you're going to meet the eligibility, but by no way are you meeting the needs of all of the children in your communities. So focusing on quality, as the previous speaker said, quality is such an important part of early care and education. And it's often overlooked when it comes to, you know, the issue, how do we get to quality programs when we are not investing enough money in some of the quality drivers that we have. So we estimate the cost of providing high quality infant toddler care somewhere between $12,000 and $21,000 annually, and we base that on the work that's been done on the Early Head Start Child Care Partnerships, where we doubled the amount of money going into a child care provider's program per child and essentially got the quality up. So while the quality costs somewhere in that range, the average subsidy payment for an infant through the Federal Child Care Development Fund is $6,800, roughly half of what it takes to get to quality. And therein lies our problem. We have this gap between what people can afford or the federal government is paying in subsidy rates through the states and what it costs to do this well. So we're going to have to, over the next few years, figure out how we basically can fund this program so that at the same time we provide quality, we give our teachers a pay that they themselves can live on. So just looking at state funding quickly, because I know we're getting close to out of time. The issues around the states and what the states are putting in, most of the states are putting money into public pre-K, and this slide shows you about what has gone on. There's been a big increase in state dollars going into pre-K, but again, it's a part-day, part-year program, mostly for 4s and some 3s. Numbers are on the slide about how many of each of those age groups are served. And go back to those numbers of 12 million children, and we have a gap in where we are providing services to our children. This slide I wanted to just point out because I believe in public shaming, in that states, when they get their child care development funds, they have to match some of their funds with state funds. And in some states, when they don't match the money is returned to the federal government and reallocated to other states. This shows in 2016 the 4 states that did not meet the match, so they could not draw down all their money, and they actually returned money to the federal government. Those states are up there. It's Idaho, Kansas, Michigan, and Tennessee, and we just want to encourage them, if we can, to match that federal dollar so their families can get the services. So the next thing I wanted to talk a little bit about and then get on to a summary is what we've been trying to do here in looking at this fragmentation and overlap issue. We issued a report in 2018 looking at the state systems around how they support early care and education, and basically looked at how many departments are overseeing this. In this report, we have a profile of each of the states, and you can see the report up there, and you can link to it and link to your particular state about how you are organizing early care and education, with the assumption being that the more efficient the state is, the better off we are. So the state sheets are in there, and I will say to the audience that we verified every state's data with someone in the state so that we got it right. We gave the states an opportunity to look at their data and tell us if we had it right or wrong. I will tell you that there is a lot of flexibility at the state level. Of the 9 federal programs that were on the previous chart, it is completely up to the state for 8 of those programs how they are administered. So whereas the governors and the state legislators sometimes think that they can't do anything about this and that the stovepiping is caused by the federal government, it is not. And it is not caused by Congress either. It is strictly state decisions. So the next slide looks at in 29 states, there are 3 or more agencies administering these programs. So our premise is here that it is harder to coordinate and administer these things when they are not located and they are not, they do not have some kind of common administration. And I would back on that slide, the 2 biggest states, in Texas and New York, there are 5 agencies administering the 9 programs. The next one just looks at where there's a concentration, where they are located together. It shows kind of the opposite of the previous. So you look at the states that are most efficient. We were very happy when we did this work to see that this is not a red state or a blue state issue. It really is about leadership within states and how do we begin to manage the program. Okay, the next thing that I want to put on your radar screen for people in the health world is that there are by law states are required to have state advisory committees. This was a requirement in the 2007 Head Start reauthorization. Right now, 45 states have them. These are state advisory councils, and I say that because the health and mental health agencies in the states are required to participate in these state advisory councils. And these state advisory councils can have major impact on quality decisions, on budget decisions, on how these programs are administered. So it's important that if you're in the health community, you find out if you're not involved with this work that you get involved with it. Finally, I want to just talk quickly about quality rating improvement systems. We have in this country quality rating improvement systems. Sometimes these are aligned with other things in the state, and sometimes they're not. And so what we are trying to point out here is that licensing and quality rating improvement systems need to be linked, because if they're not, we have created 2 different systems that are confusing to parents as well as to child care providers. So this is a place where health community can get engaged and help us out. We really need to align both the inspection process of early care and education programs as well as the standards. And if these programs are not linked, sometimes we have 2 different sets of standards, 2 different inspection requirements, etc. And we think that there's a lot that can be done to improve that. So just to summarize where we are on our work, we are making recommendations to governors and state policymakers about administering these programs. Generally speaking, we think that government does not do a very good job of reorganizing itself. So we're recommending to governors and state people to have an independent look at how you organize your programs to make sure that they're efficient for both families and for the child care providers working around in these programs, that you set up coordinated monitoring systems to ensure that your licensing and your standards are at least aligned, if not the same, and that you look at data integration. It's a very important thing, and it's a tough one, we know that. For Congress, our biggest recommendation is to look at eligibility. That because if Congress is at fault for any reason on the issue of early care and education, it's because the eligibility requirements for participating in the programs vary widely. For example, child care is 85% of state median income for a family, but Head Start is poverty or below. So we're making some recommendations to Congress to align eligibility requirements. And then the final one is the integration and alignment of the early intervention system. That we try to take a look at how we align the Part B and Part C programs so that families with young children can stay eligible until school entry and get those early screening and support services that they need. So with that, I'm going to turn it back over, and the slides will be available, and if you have any questions at the end, we'd be happy to take them. And thanks again to NIHCM for inviting me.
Thank you so much, Linda. And while the challenges can seem daunting, your work sharing best practices certainly seems to be starting to make a difference, and look forward to folks on the call taking advantage of looking at your resources in their states and seeing how we can help more children receive the strong start that they need. Next, we will hear a state and local perspective. Our last speakers are Allison, Corrado, and Rebecca Noecker, joining us from Minnesota. The Blue Cross and Blue Shield of Minnesota Foundation is a trailblazing leader in efforts to address health disparities in Minnesota and build healthier communities. They've taken a strategic approach to addressing the drivers of health inequity by establishing strong relationships with community partners. One of their primary programs focuses on improving access to high-quality early childhood education, programming, and training across the state. In her role as Senior Program Officer at the Foundation, Allison leads their Healthy Start early childhood efforts. She's been with the Foundation for more than 5 years and is a passionate leader in their partnerships to advance health equity. Allison is joined today by one of their Healthy Start grantee partners, City of St. Paul 3K, represented here today by Councilmember Rebecca Noecker. Councilmember Noecker is deeply invested in creating opportunities for young people and is leading a team working to expand access to high-quality pre-K in St. Paul. Thank you both for being with us today, and I'll turn it over to Allison to get started.
Hi, good afternoon. I'm going to start with just a little bit of information about who we are at the Blue Cross Foundation. We are a statewide corporate health equity funder. A few years ago in the strategic planning process, we embedded health equity into the center of our mission statement. So you'll see it there on the screen that we make a healthy difference in communities by advancing health equity and improving conditions where people live, learn, work, and play. In the health realm, we talk about the social determinants of health, and that's what we're referring to there. We at the Blue Cross Foundation are both a separate and a highly interconnected organization with Blue Cross and Blue Shield of Minnesota, our statewide insurance provider, and we make grants to nonprofits across the state of Minnesota. That's our approach, is investing in communities. We have about $60 million in assets, and that is dedicated exclusively to improving community health across Minnesota. And what that looks like in a year-to-year, we, in 2018, made about $3 million in grants to organizations. So we're a fairly small funder. All of the work that we do is grounded in much of the research that you've heard about in the earlier presenters of this webinar. We know that health happens in the community. When we look at all of the things that influence our health outcomes, 40% of those are these social and economic factors. These are things outside of a clinical environment and often things that people lack control over. Although we know that despite what we know, health spending does not reflect what actually influences our health. So of the about $9 trillion that we spend as a nation on health, about 95% of that goes to direct medical care services. Only about 5% is allocated to population-wide approaches to health improvement. So we're backwards in lining up our funding for what we know really matters for our health. Here at the Foundation, we focus on 3 different programs, and I'll talk briefly about 2 of them and then dig in deeper into our Healthy Start portfolio, which is our early childhood education work. The first is Healthy Connections, where we're working to create and build and improve on safety and feelings of welcoming in communities around the state. We know that when people feel safe and welcomed, they can experience better health outcomes, things like lower blood pressure and stronger immune systems. A second body of work around access to coverage, working towards universal insurance coverage across the state of Minnesota. We know that uninsured people are far more likely than those with insurance to delay health care or to go without it entirely. And we know that these effects can be really devastating, particularly when things are preventable or life-threatening conditions are left untreated. And then the body of work that I lead up is called Healthy Start. We know that you've heard all of these things so far today, but what happens in the first 5 years of life sets the stage for lifelong health. This is our key driver. Children who participate in these high-quality early childhood programs experience a range of both immediate and long-term health outcomes. So our approach to health in this Healthy Start portfolio is really long-term. We're looking at the immediate, but we're looking at also some of the research that was already discussed, that 30 years down the line when these little ones are adults, they're healthier. Within Healthy Start, our goal is to make a healthy difference in communities by advancing health equity in early childhood care and education by focusing in on communities that lack access to high-quality early childhood care and education for reasons that are really beyond their individual control. And we fund organizations that are working at the intersection of health equity, which we define as a state where all people can reach their highest level of health, high-quality early childhood care and education for 0 to 5-year-olds, and systems change, where we talk about intentionally changing parts of systems and structures and policies, as well as things like power and mindset and infrastructure to advance health equity. And organizations that we support must create or contribute to systems change and move beyond providing direct services. What that looks like on the ground is, for our funding, we're currently funding 10 nonprofit organizations around the state that are all focused on increasing access and improving the quality of early childhood care and education. We know that there's just not enough childcare in the state of Minnesota. All but I think 2 counties in the state have a significant childcare shortage. But as you've heard over and over again in this webinar, the quality really matters. We're not interested in creating new childcare that is poor quality and isn't going to support young children in the way that we want it to. These organizations range from really large regional operations across the state to really small grassroots organizations or even fiscally sponsored projects, as you'll hear from when Rebecca talks a little bit about her work. We are clear with our incoming goals related to access and quality and what we want to see changing and the trajectory. But how the work gets done is very up to the individual organization and what works in their community. We do a lot of work up front when we're deciding who to fund to intentionally fund organizations that are constituent-led and are meaningfully engaged with the communities that they anticipate will benefit from the work that we do. And we think that that's a really key strategy for our funding, is to really get as close to the people that are affected by the problem through the organizations that we fund. So we know that the approaches that they'll use will all be different, but they'll all be designed in mind of the people that will benefit from them. And examples of this work include supporting child care programs, to participate in our state's quality rating and improvement system. In Minnesota, it's called Parent Aware. Things like coaching to child care providers, creating social emotional curriculum, and training licensed family child care providers to really use and adopt the social emotional focus in their programs. And in a minute, you'll hear a little bit more from our grantee partner about their work and how they're building this quality early childhood program using this private-public partnership model, really to expand access to all low-income kids in our capital city, St. Paul, here in Minnesota. We track all of the work that we're using an evaluation framework, and we're seeing that what we're doing is having a huge impact in the communities that our grantees are in. Results from a first evaluation checkpoint indicate significant progress towards goals. Things like over 600 new child care slots have been created, 1,000 child care providers have been trained in quality programming. There's been over 4,000 hours of technical assistance and coaching provided, 27 new licensed child care providers, and 90 providers receiving a Parent Aware rating. So fairly small numbers in the scheme of things when you look across the country, but in Minnesota, these numbers are huge. And we also keep our eye on community level indicators and think about how the outcomes our grantees are achieving really contribute to this larger picture. So contribute, I think, being the key word here. We know that our funding alone is not going to directly move these community level indicators at a substantial level. What we're doing is contributing to a larger change, and I think that that's really fantastic. So ideally, a statewide indicator on something like kindergarten readiness would be fantastic. In Minnesota, we don't have that. That would be, we would consider that a strong proxy measure for educational success. But unfortunately, we don't have that statewide. So some of the community level indicators that we use are tracking statewide data on child care shortages and using our state's quality rating and improvement system to track participation for programs around the state, and looking at where there are gaps and opportunities to provide a little additional support through our philanthropic funding, and how we're moving forward. And with that, I want to pass it over to Rebecca to talk a little bit about the specifics of what she's doing in St. Paul.
Great. Well, thank you so much, Allison. Thank you to everyone for the opportunity to be here. I know that I'm all but standing between you and the opportunity for Q&A, so I will be mindful of that and hopefully be engaging in the last presentation here. I'm really grateful for the opportunity to be part of this and to Blue Cross and Blue Shield for their support of St. Paul 3K. And I think it's fitting that this is coming at the end of this webinar because this specific on-the-ground local effort is really motivated by so much of what we've been talking about here today, the just overwhelming need and the need to take action. And I know it's easy to be in these webinars and to be in a lot of the conferences that I sit in on a daily basis and get really discouraged by how much the need is and how much needs to be done and how long it's taken to see action, especially on the state and federal levels where the responsibility for this action lies. And that is why in St. Paul, Minnesota's capital city, as Allison mentioned, we have decided to take matters into our own hands and create our own citywide pre-K program that meets the needs. So the mission of St. Paul 3K is to coordinate and expand access to high-quality early learning for all 3- and 4-year-olds in St. Paul. And this is both from a kindergarten readiness perspective, from an achievement gap perspective, for all the other health and social and economic indicators we talked about before. But I would also add that as a city, I'm on the St. Paul City Council, and from a city perspective, we see the benefit not just in student outcomes and for family educational outcomes, but also for economic development, for workforce development. We're trying to attract companies to St. Paul. We're trying to attract millennials to come work here. And being in a state where it's really hard to find and afford high-quality childcare is a detriment to those efforts. So we see this as an economic development opportunity for the city as well. And we are, by the way, not the first city to do this. We're following in the footsteps of dozens of other cities around the country. Maybe many of you live in those cities or in states with those cities, but from Boston to New York, San Antonio, Washington, D.C., Cleveland, Dayton, Denver, lots of other places around the country have created their own city systems as well, again, motivated by the sense of frustration that states and the federal government are not fully funding this work themselves. So the need in Minnesota is pretty extreme. We're the fourth most expensive state in the country for childcare. A third of kids in St. Paul live below the federal poverty line, and 3/4 of them live below 300% of the federal poverty line, which is about $75,000 for a family of 4. So 300% of the federal poverty line is still really not making that much money. And our early learning scholarships in Minnesota, which is a form of childcare subsidy, only go to the lowest income families, so children below 185% of poverty, and they don't cover the full cost of care. They typically cover about 7 months worth of care. We have a number of families who are on wait list for child care assistance that we do have in Ramsey County, where St. Paul is located, and we have a number of preschool seats that are not rated at all by our quality system, Parent Aware, and 56% of our kids come to kindergarten not ready by the assessment that St. Paul Public Schools uses. So we know that the need is incredibly great. Our approach has been to really start from the beginning and keep the end in mind. We know this is a long process. We know that it's not easy to overnight solve all of the many problems that we've been talking about on this webinar. We started about 2 years ago creating a high-level blueprint for what this work might look like. We then created a leadership structure that includes members from the city, the county, the school district, Head Start, Generation Next, which is a collective impact organization here in the Twin Cities, and a number of other community and elected leaders to try to take this work forward, because we know we're going to need everybody on board to move something like this in St. Paul. We're now working on building the framework, which is taking the 30,000-foot blueprint and bringing that down to a much more on-the-ground level of detail for how the program would actually work. And we've been very intentional about involving families and providers in designing the framework, and I'll talk more about that in a second. And then we're also working now, and we'll need to continue working to build the political will, because we know that a program like this, which is going to cost roughly $15 million a year for the first couple years and about $27 million a year at full uptake in year 5, and that's on top of all the other federal and state assistance we already receive in St. Paul, that's going to take significant political will. We're talking about a local option sales tax. We're talking about a property tax increase. We're talking about soft drink and sweetened beverage taxes. These are some of the mechanisms that other cities around the country have used. To put that in perspective, a 1-cent sales tax in St. Paul, so 1 cent on every dollar that you spend, yields about $36 million a year. So it is incredible to see how some local funding options really can meet the need. You just need the political will to do it. And so that's what we're doing now, advocating with local and state leaders to allow us to make these investments. And those stakeholders include the healthcare sector. And I wanted to point out that healthcare has been at the helm in not only here in St. Paul. We're really lucky, as I mentioned, to have Blue Cross Blue Shield and other healthcare partners supporting this effort, but also in other cities that have created citywide pre-K systems. And I've listed some of them here, just so you can see that in your community there may be an opportunity to be involved in a local effort like this. And it's for all of the reasons why we're all on this webinar, that we understand and healthcare understands the impacts that early childhood education have on health and on all the outcomes that healthcare systems are trying to achieve. So our program elements in brief, just what exactly is St. Paul 3K going to look like? It's a mixed delivery system, which means that it's going to include all of the existing providers. So we have our St. Paul Public Schools, charter schools, we have child care centers in family home environments and also in institutional centers. All of those are going to be invited to be at the table. We're going to have a metric of quality to make sure that the providers are providing quality education, and we're going to support them towards that goal so that we can include as many of them as possible and support them to reach our quality standard, and of course evaluate results. We want to make this simple for families. So right now, finding care can be its own challenge. Even if care is available, figuring out where it is can be challenging. So we're going to have a common application, a one-stop shop. We're going to fully fund families at 300% of the federal poverty line and below. So again, that's families of 4 making $75,000 a year and less will be fully funded if they want full-day year-round care, if they want half-day school year care in any setting. And above that, we'll have a very generous sliding scale of tuition subsidy. And as I mentioned, the annual cost is about $15 million in the first year, and we anticipate it will be about $27 million by year 5. And again, we know that we have local funding sources at the city level that can cover those costs. We would love it if the state of Minnesota tomorrow decided that they would cover the cost fully. And at that point, St. Paul 3K can transition to becoming St. Paul 2K and fully serving 2-year-olds and 3-year-olds. And we can continue taking the model down because we know that eventually what we really need is a 0 to 5 system. And finally, just a quick word about the way that we're involving the community in the design of this program. As Allison mentioned, community engagement is really a top priority for Blue Cross Blue Shield grantees, and it's been a top priority for us from day one. We know that parents and providers are the ones experiencing how the system is broken now, and so they're the ones who can help us fix it. So we have engaged a couple of consultants to help us work with parents and providers. We've engaged over 200 parents in one-on-one meetings and listening sessions in grocery stores and coffee shops, in school district settings, and then 79 different providers have been reached, mostly licensed family child care centers actually, through listening sessions and through a survey. And actually in about 2 minutes, I'm going down to a steering committee meeting of some of those elected officials to talk through the 90-page reports that we've received on their feedback, but it's been invaluable to see how they think both this program is needed and the specific design elements that they want to see. But there seems to be universal interest and consensus that this program would be a game changer in St. Paul. And I know that my slide isn't the only one available for questions, but I thought that picture was too cute not to include, and my contact information is there. Thanks so much.
Thank you, Rebecca and Allison. Your public-private partnership is a great model for how to build a coalition around investment in upstream solutions to problems of health inequity. We're so glad you could join us. Now we want to hear from our audience. What questions do you have and what information would be helpful for you to know from our speakers here today? You can submit your questions via the webinar console. I'll start with just a clarifying question for Allison and for Linda. Allison Baulos, we had a couple questions about what is the criteria for defining high quality child? Linda, you had referred to the adult to child ratio. Some of the programs that have been mentioned, like the Perry program, they have a 1 to 5 adult ratio, weekly home visits, master's level teachers. There's so much that's high quality. How do we define that? And then also, what is the research about how close to the original model do we need to get in order to achieve these same benefits?
So, a few things there. There are a lot of groups studying different measures of quality, and just to plug, it's not our group, but there's another group out of the University of Chicago called the Consortium on School Research, and they were working with the Ounce of Prevention, and they did an analysis on what they call the 5 essentials of a quality program, which included instruction, so strong focus on the curricula and professional development, teachers that were collaborating together, involving the families, and supportive environments so that they're safe and emotionally engaging, and then ambitious instruction, again, with a developmentally appropriate curriculum. So I find that research pretty interesting. What we know about Abecedarian and Perry, both of these, they are relevant to today. A lot of the core components are what you would find in programs today. Again, the professional development of the teachers and ongoing coaching, the developmentally appropriate and child-focused, child-led curriculum. So plan, do, review, I think, is peri-preschools, and which is now the high scope curriculum. And Abecedarian had a strong focus on language, and again, started at birth. And both had socio-emotional components. And Peri was a part-day program, so it looks more like what we would see as a preschool, but included engagement. You said those home visits and engagement with the families, which we see are really important. And like I said, there's a 3-gen effect, so now we see effects on the children of those participants, particularly on the boys. They were more likely to have a father at home, those fathers being the participants in the program. So there's a lot of channels there. But whether, I think the last part of your question was, again, how do these relate to programs today? High scope is used pretty widely. I think a little over 10% of Head Start centers are using high scope. And, you know, so how you want to talk about different curricula, you can just think about quality in terms, again, of the teachers. And we know that there are still room for improvement there, professionalizing the early childhood workforce and increasing the wages. A lot of those workers are parents themselves. So there's a lot of ways to look at it.
Yeah, this is Linda, and I'd like to add a couple things to that. I do think that, you know, obviously, you know, the sort of the instructional support and I think at the end of the day, we know that the quality of the adult-child interaction is what is probably the most important, and what that looks like and how we get to that quality depends on the preparation of the teachers and some of the other things that they're doing in the classroom. I think that, you know, the other thing that was just mentioned that's so important, and I think I said it in my remarks, is that parents are engaged. And I think that's, you know, from where I have come from over the many years, looking at Abecedarian, looking at the Chicago parent-child centers, looking at high scope in the home visiting, they all have a parent component to them, and they all involve the parents, whether it's through home visiting or parents in the advisory committee. So I think that I can't say enough about how important it is to keep parents involved. But to the point also of this, of the group that we're talking to today, I think we have got to, you know, we have to say that it starts with sort of the health and safety of children. Children can't learn if they're not healthy, if they're not safe, if they're hungry, they can't learn. And I think we've got to look at the, you know, the comprehensive nature of what it is we're trying to do here. Head Start program, counter to a lot of what is said about the program and the fade-out issues, Head Start does work. It gets children ready for school. They arrive at school on a par with their peers. I always say, you know, that what happens between kindergarten and third grade is out of our control. But Head Start works, and it also works because it involves parents. It has comprehensive services. It makes sure their children are screened, they are healthy, they're getting nutrition, et cetera, et cetera. I agree with what the previous speaker said about the curriculums. I think the key word is evidence-based curriculum that's developmentally appropriate and looks at individual child needs as opposed to, you know, large group instruction. And I would add those to the sort of what has been defined as high quality.
If I can build off just a quick point that Linda raised, because it's brought up a lot, is on fade-out, this cognitive fade-out, and indeed a lot of people criticize Head Start and that impact study that did show that. But of course, gaps show themselves really early, and then by kindergarten and third grade, people are looking at, you know, reading scores or something like that. And what's happening is a control group would be catching up, but then when you look longer term, because the peri-preschool study did show a fade out, but then when we follow them at age 15, 19, 21, 40, 50, we're seeing those longer effects. So that's just something that's temporary and really just a focused cognitive score.
Great, thank you. This question for Allison, Corrado. You mentioned some of the community indicators that you're looking at. The question is, are you planning to look at third grade reading scores as a longer term outcome for this work?
Yeah, so we look at the kindergarten readiness information that's available, believing into this trajectory of when kids start kindergarten on track and ready to learn, they are more likely to be at reading at grade level by third grade. They're more likely to be up to speed in math by eighth grade, sort of these indicators along the way that predict whether or not a young person will graduate high school on time, which we have as one of the biggest predictors of lifelong health. So looking at kindergarten readiness is just sort of one of the indicators of lifelong educational outcomes, which then connect to health. So definitely along the continuum, there are key touch points to sort of track if a kid is on ready, but we know that it's all cumulative and it all builds off of that foundation of early childhood care and education and kindergarten readiness.
Great, thank you. This is a comment and a question, so I will read it. In Florida, they have voluntary pre-K that's funded by the state, but it is not adequate to ensure quality for all children. The assessments to measure quality are not working yet. The test for kids was given by a computer using a mouse, but young children don't use a computer mouse, they use touch screens. Do any of the speakers know what assessments have been effective to know kids are ready for school?
That's a good question, and I think I would point to sort of what has happened over time in Maryland, and I know they changed their system, but Maryland implemented a kindergarten readiness assessment in the fall of the child's entry into kindergarten statewide back in about 2000, and you can go to the Maryland website and see some of this. What they did, and they worked with Sam Mizels out of the University of Nebraska, who's probably an expert in this whole area. They developed an instrument and they assessed children at that point. I think the interesting thing about the Maryland model and why I think that a lot of states should be thinking along these lines is it tracked children. When children come in, then the parents would say where the children had been prior to coming to kindergarten. So they were assessed, and then there was a look back. Are these children coming from home-based child care, Head Start child care centers, nothing at all? And looking at children, and then in Maryland, they would go back into the communities if the children were coming basically unready or not ready for kindergarten as they assessed on this instrument. They would go back and work in the community where the children were coming from. If it was family child care, they would work with providers to get them up to speed. If it was center-based or there was nothing, they would work with them. So I think what we have to do is not just look at individual measurements, but how are we using these assessments to figure out how to create a more comprehensive system that reaches kids where they are and helps this be a burst to 18 continuum. And I don't know if that answers the question, but I do think looking at the Maryland school readiness model, there are a number of states right now looking at school readiness instruments. Some of that work was funded by Race to the Top several years ago and is ongoing. It's pretty individual by state, though.
Great, thank you. Allison, a question about the St. Paul 3K system. I know you're one of the funders. Are you able to talk about, how else that project is receiving funding and sort of also generally like how you're collaborating with other funders in the state to support the early childhood programming?
Yeah, so we are one of a few funders of the St. Paul 3K work. It's a pretty small program at this point. They're a fiscally sponsored project. And so what we're funding is some of their work around community engagement, engaging with families to make sure that any program that they create is really deeply tied in with the families that will benefit from it. But there are other private funders who are supporting that work as well. And to the question of our connection with other funders, in Minnesota, we have a fairly robust funder collaborative called the Start Early Funders Coalition that brings together a number of funders really statewide, some that are really focused on regions, some that are really narrowly focused on early childhood policy, some that are focused on early childhood health and early childhood screenings and things like that, and an opportunity for us to come together and learn and grow. So we're not a coalition that pools money and makes grants in that way, but we're a coalition that comes together to hear about what's going on and stay connected to work that's happening on the ground and have that inform what we go back then and fund so that our work is all driving towards the same thing. And this has been around for a number of years and has looked different over the years, but I think is a really important way for funders to do their work. I mean, both by being deeply engaged with their grantees and with folks on the ground, but also with other funders that we can influence and we can try to shape what the philanthropic sector is doing in the early childhood space, so we're not getting in each other's way, or we're not duplicating things that are unnecessary, and we're sharing in real time things that are working and things that aren't that will help inform other funders. And that's been a really wonderful experience.
Great, thank you. This is another question for Allison, but any of the speakers could touch on it in terms of their experiences. In system planning, to what extent have the social determinants of health been studied, specifically families' housing instability and homelessness, and how might this impact childhood programming in St. Paul and beyond?
Yeah, I would say we know that children do not exist in vacuums, and that all of the things that affect children's lives really matter for their development. Looking at the ACE study and an understanding that we're working with children that live within families, that live within communities, and it's really important to think about all of those pieces. You know, one of the things that we have been looking at here at the foundation is the intersection between our different bodies of work that I mentioned during my part of the presentation. So thinking about creating safe and welcoming and connected communities and young children having access. And one example of something that has just been really cutting across all of our areas of work is around public charge and families, particularly immigrant families, being really concerned about what it means to take government assistance, even when we know how much of an impact that has on their long-term health and on our community health, and thinking about how to support our grantees to think about and work with their folks on something like the public charge rule and other policies that come up. That's just one example, but thinking about the intersections between all of the work because we know how layered this is.
I would like to add one thing to that, if I might. I think in terms of the homelessness issue, I think that there's been a special interest at the congressional level on this, and I think in the Head Start, when we rewrote the Head Start performance standards, there was a preference given to homeless children in terms of Head Start slots, trying to get at some of this issue, and I believe there's also some priorities for child care assistance around that issue too. I think the population, especially of homeless children, are very high risk, and in some cases the only stability in some of these children's lives is the child care or the preschool program or the Head Start program that they're in. So it's pretty important that we pay attention to this and try and figure out how we can reach these families, because a lot of families are out there with very young children homeless.
Great, thank you.
Can I add one thing too? In Minnesota, with our quality rating and improvement system, we give priority for scholarships for that program to young kids that have been homeless in the last 24 months. Another funding stream, another avenue to target to kids that really need supports.
Great, thank you. Rebecca had mentioned, the ultimate goal of reaching, even younger children, birth to 5, but we had a question about what are some of the best options for reaching children 0 to 2, either in the home setting or a child care setting, for any of the speakers.
Well, I think one of the things is through the home visiting programs, and the federal government did invest quite a bit of money in the last 5 or 6 years into home visiting, evidence-based home visiting models, and I think making the connection between home visiting and the early childhood community. When in the last administration we spent a lot of time looking at the continuum prenatally through entry into school, with home visiting being a critical link in the earliest years of making sure that children get connected to the right services. So I think, and I know many states and many communities, in addition to the federal programs, have invested in home visiting. And it gets back to sort of some of the issues with even the Abecedarian and the high scope program. They included home visiting, and I think we cannot overlook the importance of those programs in our families' lives.
And I'll add to that. We know about $400 million a year is spent through MCV on home visiting programs, and we do want to understand, we at our center and with other groups really want to understand what is it about those home visiting programs that drives the biggest return to evidence. There are, I think, maybe 20 or more programs that are, quote, evidence-based, but they have a variety of outcomes on different dimensions. So we want to understand what's going to look best through different delivery models and which of those can scale up. We did look at a program in Jamaica that is one of the more well-known programs. So this was 30 years ago. We did a follow-up at age 23 and now are working with partners at the University of West Indies to look at the effects at age 30. And at age 23, we did see strong labor market outcomes. So we do know that, again, there is still long-term effects to just the home visiting programs focus on 0 to 2. And the Jamaica program itself is particularly compelling because there wasn't a lot of, these were not highly skilled or educated home visitors. They were from the local community, and so the cost of the program is quite low, and it's being scaled up in different parts of the world. So now we're trying to get those data to understand what that looks like in different populations.
I think one other area to add to think about having an impact on is in informal care settings or family friend and neighbor providers or the legally unlicensed child care providers, knowing that, at least in Minnesota, there are about half of our children are in these informal care settings in some form. And we know that that's care that a lot of our communities of color are using because of the affordability and the cultural relevance and consideration of what's best for their families. And so I think it's really important to make sure that we're including informal child care programs when we're thinking about how to improve quality, how to engage with families, and I think it's a really great way to reach some of those youngest children too, thinking about young children and siblings and parent engagement.
And in thinking about these programs as 2-gen or 3-gen programs, home visiting not only benefits the child itself, but a lot of these are working with the parent. So what you're doing is the home visitor is not working with the child directly, they're working with the parent to work with the child. So the effects go beyond just what happens during that 1-hour weekly visit, and a lot of times they're also connecting the family to different resources to help, with food stamps or domestic violence or mental health, maternal depression. I think when you look at the effects beyond just developmentally for the child, you'll see a high return.
Great, thank you. We have a few, sure, go ahead.
I just wanted to add one thing in terms of this discussion around, sort of the healthcare and the early childhood community writ large. It always occurs to me in that when children go to see, like for instance, their healthcare provider, I would love to have the healthcare community put the question on every checklist, is your child in child care? Because I think too often that question doesn't get asked, and some of the issues that surround early childhood, child development, child illness, don't get asked in the context of where the child is. And the other piece of that is early intervention services. When children are involved with either Part B or Part C services in a community, is the child care provider or whoever the child is with during the day a part of the conversation? Because you can have a conversation with the parents about what the child needs, and the parent will then go back to the child care program, drop the child off, and the child care provider who has that child for 30 or 40 hours a week is in the dark. And so I think if there's some way of bridging, if there's one thing that can be done to help bridge early childhood and health, it can be asking each other these questions. Is the child in child care, the child in pre-K, and vice versa? Is the child seeing a doctor? Is the child in getting other services from the early childhood side? And I just put that out there because I often get the question about bridging between health and child care or the early childhood community, and that is an easy way to do it.
Great. Well, that might have partially answered part of some of the other questions that have been coming in about, how can we collaborate with pediatrics and especially child visits. There's a couple questions about how Medicaid agencies can partner with early childhood to engage families. And just, I think the question is just asking kind of the speaker's take on that.
I just really think that communication, and I do, it is so important, as I said in my slides, is from my perspective, that children get screened early and often. And how does that happen? Medicaid is a big provider of screening services, Part C, some of these programs that we have in communities, but not only do children need to be screened, then the follow-up has to occur, and how that follow-up occurs can be critical for children. So as I keep saying, if the providers, whoever's providing the care, whether it's an in-home provider, a center-based provider, a Part D preschool, they need all the information in order to help children.
Great. Well, we are at the end of our time together, so I do want to thank our excellent panelist speakers for taking time to be with us and to answer all of these great questions. And thank you to our audience for joining us. We hope that you've learned about some evidence-based programs and have taken some ideas, can take some ideas back to your work and your communities. We'd appreciate it if our audience could take a brief survey to share feedback on this event. You can find that on the bottom of your screen. And again, if you missed any of the presentations, we will be sending out an archive of the event, and you can find the slides on our website. So thank you all again so much for joining us today.